Bismillah ar-Rahman ar-Rahim. This is the bronchology 3 session. It's my honor and pleasure to co-chair this session with my friend and colleague, Professor Gamal Rabia. Let me call the first speaker in this session, Professor Lutz Freitag. Actually, Professor Freitag has two presentations yesterday. I will not going to go through his very long and rich CV. He's from Germany, co-founder, chief scientific officer, consultant of several biotech companies, especially in pulmonary and general internal medicine. Presentation of Professor Freitag, the functional bronchoscopy, bronchology meets pathophysiology.
Yeah, thank you very much for the warm introduction. Well, the topic that I'm going to cover is a little bit exotic. Not everybody is doing it now. Hopefully next year, if you have heard my talk, because I think there is much more possible with a bronchoscope than what we do today. By the way, it's a long talk. I have 40 minutes. I try to make it shorter, but I cannot promise because I have several video clips. Okay, let me start with a case. You see the resistance curves of a patient, and it's the same patient. In between these two measurements, there are only a few minutes. What can it be? It cannot be a stem bronchostenosis because that usually doesn't develop within seconds. So, was a puzzling case. Many years ago, you can tell from the quality of the images. And what you see here is the flow at the mouth. So the patient has a pneumotac, and you see the vocal cords, the larynx, and you see the breathing pattern. And then a few minutes later, same patient, there is no expiratory flow. This is only the inspiratory flow, and during expiration, the vocal cords narrow. Hardly any air comes out. This is vocal cord dysfunction. Vocal cord dysfunction is a strange disease. It's a disturbance, and we do not really know where it comes from. But there are estimations that 15% of our so-called asthma patients in reality do not have asthma, but have a problem in the larynx, which has been undetected. So what we do now, patient has a pneumotachograph, we do a bronchoscopy, and simultaneously register the flow at the mouth and take a look at the larynx, the vocal cords, and as I show you in a moment, also the trachea. So the system consists here, this was the third generation of a pneumotachograph, and via Bluetooth it sends the signal to the computer so that it's overlaid. When we talk about disturbance, the question is what is normal? During normal breathing, this is the triangle of the vocal cords. There is some narrowing, and this narrowing is whenever the flow reaches an inflection point. So at very high flow, we have a wide opening, and during expiration, there is slight narrowing. And this slight is the key word, because if it's too much, then it's a disease. Hardly ever the vocal cord dysfunction becomes life-threatening, but there are a few cases, and this is one patient who always lost consciousness and required a tracheostomy. So what I do here in this patient, I go through the tracheostomy and look upwards, retrograde into the vocal cords. And you see that the right vocal cord is not moving. So without the history, you might assume, okay, it could be a recurrent nerve alteration. But then I just gave this patient propofol and see what happens. Within seconds, the right vocal cord opens. So just by making this patient unconscious, the breathing was normal. we do not know what it is, but there is definitely something from the brain uncovered that influences the vocal cords. If we had not known it, we would have gone for MRI and all this work up for recurrent nerve paralysis. But here it's a strange neurological disorder. When we have patients and with all kinds of diseases and we take a look at those, you see sometimes these strange patterns with stop of breathing, apnea phases, and normal phases. And you can tell from the shape of these, let's say, flow curves. So it gets bigger, and then it gets smaller and smaller, and then we have an arrest. And this is in patients with right heart failure. This is Cheyne-Stokes breathing. The question is, what do you do with Cheyne-Stokes breathing? And many of these patients get CPAP or BPAP devices. Fact is, in Cheyne-Stokes patients, the vocal cords are closed during this apneic phase, so CPAP would not help. This is in contrast to patients with obstructive sleep apnea. This is a strange case. A patient came to me with amyloidosis. In the bronchi, some spots of amyloidosis. But I took a look at his vocal cords, and you see this strange pattern, almost Cheyne-Stokes breathing, very disturbed, and tremendous narrowing, so these vocal cords never ever opened completely. So this is a severe disorder, and in this case it was a neuroamyloidosis. So this disease had affected the brain, and that had resulted in obstruction of the airways because the recurrent nerves didn't fire. Many of these patients are in states where they say they cannot exercise, they cannot do this, they cannot do that. Others say, whenever I smell a lemon, I get unconscious. So you have to find the trigger event. And many trigger events are exercises. Other trigger events are aspiration of acid from the stomach. So when we suspect exercise-triggered events, we have the patient on a treadmill, measure and take a look at the vocal cords. This is a young boy who has been an athlete in school. And then one day he came to me and said, I cannot even walk to school. When I walk, I get short of breath. So while the parents were pushing him to become a basketball professional, he could not go to school. So what we did, I performed the bronchoscopy on a treadmill. And now you can see what we are doing. He is running forwardly, I run backwardly, and you see the flow and the vocal cords. Now I turn on the treadmill and he is running faster. So see from the motion that he's now exercising, and now see what happens. Takes a few seconds. Now you can already appreciate it. Narrowing of the vocal cords. Gets smaller and smaller. And now this is airway obstruction. Not from something strange, so I pushed the emergency button, and suddenly the airways opened and there was no shortness of breath. If this would have been exercise-induced asthma, stopping would not have resulted in increase of flow. It would have taken 20 minutes. This is a psychological, neurological disorder. And his shortness of breath was cured by telling the parents of the kid not to push him for sports. And since then, he has been cured, if you like. There are now many different terms of dynamic laryngeal narrowing, and it's all the same. I mean, more and more papers come out and the list gets longer, bottom line, something happens during exercise or abnormal conditions, and it is kind of answered by the body by narrowing of the airways. This is my wife who volunteered for this photo. So over the years, I've developed several of these devices where I can attach sensors and measure flow, and I show you in a minute gas exchange. So now we go a little bit deeper. This is a patient in whom I had suspected vocal cord dysfunction because of his symptoms, and this was after cardiac surgery. And now take a look at the flow curve and the segment in the trachea here. And now you see that the flow starts to get limited. It gets smaller and smaller and smaller. Again, in the trachea, not the vocal cords. So I stepped to the bed of the patient, said a magic word, and cured. So what did I say? I just said, heads up. Heads up means there's a mollusic segment, and the mollusic segment, depending how the head is positioned, is either inside the thoracic cavity or outside. When it's outside, then there is no dynamic narrowing. So this is when the head is up. This is when the head is in a normal position. You can have the same thing when you do a spirometry, just if you have confusing results between two pulmonologists, don't blame it on the pulmonologist. Sometimes the patient did a spirometry like this, while when he was in another plethysmograph, he had his head like this. So the head position is important. So what is the current treatment for this disease? Could be like this. But there are other options, and the surgeons have taken over these kind of ancient treatment option. When it comes to surgery, there are patients after surgery. This is after tracheostomy. And I do the same thing. Here is the mollusic segment, and I have the patient now scoped in this position, and you see the tremendous narrowing. Meaning, when he is in normal bronchoscopic conditions with a pillow here, we see the narrowing. However, when I have him put the head backward, it should come in a second. Well, he's now repositioning, then it's open. With such a flow curve, the patient would not need a sleeve resection of the trachea. With that position, you would. So the point is to mimic the problematic disease of the patient. It could be either head positioning, as we see here, or, for example, doing exercise. Sometimes patients come and say, when I string my shoes, I'm short of breath. So I do the bronchoscopy in weird conditions. Without conscious sedation, just with enough lidocaine, everything is possible. The trick is a good history taking of the patient and then emulating the disease. With these techniques, we can do more. I have developed a catheter with two pinholes for the pressure, and you can measure the differential pressure between 2 points. I make this a little bit shorter, so this is just the pressure swing, and then you can tell from the pressure drop how relevant this stenosis is. Because sometimes patients after tracheostomy, let's say they had a COPD, had been intubated, tracheostomized, and they come back with shortness of breath. Then we do not know whether we should take out part of the trachea or whether we should treat the emphysema. With this, you can measure the actual spot of the problem. Here, the high pressure drop between or above and below the stenosis indicates that this patient needs something done in the trachea. We can have conservative approaches, and what I do during CPAP treatment of malacia, I measure the flow, and then I titrate the pressure and see at what opening pressure the trachea stays open. And cut this a little bit shorter. Let's take a look at normal patients, or hopefully normal human beings, because this is my own bronchus here. And you see such a sinusoidal flow curve, and the airways are open. However, if we have an emphysema patient, it's a completely different pattern. During expiration, we have this abrupt flow ceasing, and we see the closure of the airways. This instability of the airways is the main cause for dynamic hyperinflation. This is why during inspiration we have a higher vital capacity than during expiration, because the air is trapped due to the collapse. So patients learn to do pursed lips breathing. That's the first treatment of emphysema. Question is, what happens during night? During night, no patient has this pursed lips breathing. Despite that, they generate somehow a pressure. It cannot be the pursed lips, it must be somewhere else. And I encourage you, when you next time scope a patient with emphysema, take a look at his vocal cords. I've seen very often that during expiration, in emphysema patients, the airways narrow. That's kind of a learned reflex that during expiration, the larynx shrinks and creates this flow break. You never see this in fibrosis patients, but you see it often in emphysema patients. We have worked on several sensors measuring the flow directly inside lobi bronchi and so forth. The problem is that these sensors are expensive, they cannot be sterilized, so it will never become a commercial product. Other topic, endoscopic lung volume reduction. We heard talks before, you put in valves, create an atelectasis, patient is happy. Sometimes you put in valves, get only a partial atelectasis. Sometimes you put in valves, nothing happens. We know now that this is due to collateral ventilations, either Cohn's pores or Lambert's channels or whatever. The question is, how does it affect the valve function, and can we measure it? When there is collateral ventilation, the valve will be refilled again and again and again. This is not new, but it had been forgotten. Van Allen in 1931 had already published in his wood box that there is tremendous collateral ventilation in excised emphysematous lungs. And we kind of reinvented it. Well, it's almost 10 years ago now, where I took lungs and emulated collateral channels by this extra tube outside. Closed the channel or opened the channel and made all kinds of measurements. In this curve, you see, this is a balloon in front of the picture. The green curve is the flow curve, the blue is the inspiration curve, and make it short, you see that nothing happens to the flow even if we put an external valve in. However, if we do the same thing, here in this patient, you see that breath after breath, the green curve is decreasing. In other words, the flow becomes lower because we create a partial collapse of the lung and atelectasis. This is collateral ventilation negative, so this would be a good chance or a good candidate for valve treatments. The system is meanwhile commercially available. It's the same thing. You get this curve, patient should get valve. You get this curve, forget valves. Next step is we have done with these systems many measurements in labs. I have relatively simple models for mechanics and sophisticated models where I have artificial heart pump, right and left heart, oxygenators, gas mixtures, and we measured what we can do through the working channel of the bronchoscope. I have attached mass spectrometers or ion mobility spectrometers, all these things that could go through the working channel of a flexible scope. 100 years ago, we already learned about endocapnometry. They had very sophisticated instruments, purely mechanical. Some coal that absorbed the CO2 and some paper scratching pencils, and they measured in right and left lung and lobes how much CO2 comes out. They even did it with a double loop intubation and measured what came out in conscious patients. Let me show you one case. We had a patient who was short of breath, and you can tell that his right stem bronchus is narrowed. Also the endoscopic view. So we figured, okay, right stem bronchus obstructed, that's why he is short of breath. But see what happens. This is the oxygen curve, the blue one, and the green one is the CO2 curve. And you see perfectly normal signals, rectangular shape CO2, sharp O2, high amplitude. And now we go into the unaffected left lung. We expect a higher oxygen uptake and a higher CO2 output. But you see there's a delay in the device. In the unaffected left lung, no CO2 comes out and no oxygen is taken up. So absolute opposite of what we had expected. And the image show that there is no left pulmonary artery. It's a Swyer-James syndrome. So it shows that we can make measurements inside the bronchi about local gas exchange. When we intend to do lung volume reduction, it's like chest playing. We have to sacrifice some parenchyma. Without parenchyma sacrifice, there is no loss of volume possible. Whether we do it surgically or endoscopically doesn't matter. We have to give something up. And what we do not want is sacrifice that is good. That's, for example, why we use perfusion scans. This part can be sacrificed if the rest of the lung can expand. And we can do the same thing with endoscopic measurements. So what I do, I have a CT, perfusion scan, bronchoscope, and then I put the catheter through the working channel of the bronchoscope, make the Chartis measurement for collateral ventilation, and at the same time make gas measurements. So this is such a system. This is in my former hospital, and see how it looks like. We go to a segment or a lobe, we have a good O2 curve, and a slightly deformed CO2 curve. The more triangular it gets, the lower the CO2 output, and here we have a rectangular shape. And at the same time, we have a very high amplitude of oxygen. So regardless of what the CT indicates, if we would sacrifice this part, we would sacrifice lung that is functioning very well. Well, if we go to another spot, hopefully on this clip we'll see it, I'm not sure. Yeah, continued. We go to another spot. There we have a lower O2 amplitude and a triangular shaped CO2, meaning this part is not functioning well, and this part can be sacrificed either by putting in a valve or operating. We have published it in respiration, if you like to take a look at the curves that helped us to distinguish and make decisions. We compared this in studies with the perfusion scan, and we have found some interesting curves. There is, for example, here the camel curve that indicates that there is a fast and a slow space. So they kind of interact. Triangular shaped ones are the one with very slow CO2 removal and so forth. Other groups do the same thing. DJ's group from the Netherlands has more looked at oxygen uptake and not so much at CO2 output. And they have correlated it with imaging techniques, sophisticated CT techniques. Bottom line is, with endoscopic measurements, you can predict the outcome and you can find the proper target. We are working on different spots of the world, in the world on these systems. This is in China. You see me here doing the bronchoscopy, and you see the different CO2 curves with just modified anesthesia machines. And this is the one that I have developed recently, where the patient is lying on a pillow, and I have all the gas sensors and video equipment attached, so I can make all kinds of measurements. There are far more options. We can induce optical catheters and have the optical signal overlaid. This gives you, for example, information about the health of an anastomosis, whether it becomes necrotic or not. You can use it for transplant patients, optical catheters, where we have special optical signals that indicate hypoxemia in parts and so forth. So the opportunities are endless. There is even more hope if you attach an instrument to the bronchoscope. We can use it for laryngeal studies, tracheal studies, stent selection. I have measuring devices for that, CPAP titration, gas exchange, regional lung function, ELVR planning, collateral ventilation. We have special sensors that indicate whether there are pseudomonas function by ion mobility spectrometry. We have catheters for lung cancer detection. Others are working on transplant rejection and so forth. Thank you very much for your attention.
Thanks a lot, Professor Lutz, for your excellent, well-illustrated talk. And it is my pleasure to call one of the eminent speakers, Stefano Giaspani from Italy. He is the head of the pulmonary unit of internal medicine. He will talk about a nice subject rose for the pulmonologist.
Thank you, Mr. Chairman, for the introduction. Well, I have to speak on a topic that is very discussed, and that is the rose. What is rose? The background is that pulmonologists use a lot of needles. Needles are important tools, but not only for dressmaker or surgeons, but also for pulmonologists. We use needles for transbronchial needle aspiration. We use needles for Hebus TBNA. We use Hebus for percutaneous approach to peripheral nodule or to mediastinal lesion. We use a lot of needles. Well, also for central lesion, we can use TBNA. For peripheral lesion, we can use TBNA, and we can use percutaneous needle aspiration for peripheral lesion or for mediastinal lesions. Well, the material obtained by needle aspiration can be immediately assessed. And the term rose has two meanings. One is a flower, And the second one is rapid on-site evaluation, that you can also call immediate cytological assessment, ICA, that is a less romantic acronym, and as Italian, I like better to call it ROSE because it's more romantic. Well, what we can find on the literature, we can find a lot of paper about ROSE. And there are a lot of papers published before 2000. You can see here just some title that were retrospective paper. And in this paper, all the author says, yes, ROSE improve diagnostic sensitivity of our procedures. And in the last one that you can see here, the authors made also a cost effectiveness analysis, and they saw that with cytological on-site assessment, the sensitivity was 81%, and without cytological on-site assessment, it was 50%. And in this paper by the South Africa group, the authors found that ROSE improved the sensitivity and decreased the time for all the operator involved in the procedure, except, of course, the cytopathologist, that spent 17 minutes more of its time to perform ROSE. In 2010, my friend Rocco Trisolini from Bologna published this paper that changed a little bit the thing. This was the first prospective study on patients that underwent conventional transbronchial needle aspiration that were randomized in two groups. The first group underwent TBNA with ROSE, and the second one without ROSE. And the results of this study were in contrast with the previous study, because they didn't find any increase of sensitivity using ROSE, but however, they found some advantages that were the reduction of number of biopsy and the reduction of complication using ROSE, because they reduced the number of passes, the number of sampling, or the number of alternative biopsy. For instance, one example, think to a patient with sarcoidosis. He has lymph nodal enlargement and he has peripheral involvement. So you can diagnose with TBNA the lymph node, and you look at ROSE, and ROSE is positive for granuloma. There is no need to biopsy the lung, so you can reduce the risk of pneumothorax and the risk of complication connected to transbronchial lung biopsy. The only limit of this study is, however, that this was performed in a center with high activity and with high competence and high skill in conventional TBNA. Following this study, other studies were published evaluating the impact of ROSE in transbronchial needle aspiration, both conventional or EBUS-guided TBNA. And this is a recent systematic review that evaluated 5 studies, 2 performed with conventional TBNA, 2 with EBUS TBNA, and 1 using both technique. And at the end, they found that the use of ROSE results in a significantly fewer needle passes with conventional TBNA. No benefit were found using ROSE for sensitivity, but the complication rate was significantly lower when ROSE was used. So the use of ROSE doesn't improve the diagnostic yield, doesn't reduce the procedure time, but it was associated with few number of needle passes and the reduction of additional bronchoscopic procedure to make a final diagnosis. Well, in the last time, you know, another problem arrived and was put to pulmonologists, the need to get adequate sample for genotyping. So this is another issue. Can ROSE help us to get adequate sample? We don't speak about diagnostic yield. We are talking about adequacy. Yes, in this study, always Rocco Trisolini demonstrate that ROSE help in obtaining adequate sample for molecular evaluation, and the adequacy was reached in 90.8% in the ROSE arm, and this is a prospective study, and just in 80% in the IBUS without ROSE arm. So the conclusion are that ROSE prevents the need for a repeat invasive diagnostic procedure in 1 patient out of 10, so in 10% of patients. That is an interesting result. And this is another study, again very recently, 2018, that evaluate as a meta-analysis the value of ROSE in obtaining the adequacy of the sample, and the conclusion were that ROSE can ensure that the target lesion is being sampled and so can enable appropriate specimen to be obtained by the correct area. And the author conclude that if available, ROSE should be used because it can minimize the repetition of procedure for additional testing like molecular studies. Well, in conclusion, if positive, ROSE has several advantages. Even if it doesn't increase the sensitivity, it reduces the number of sampling, it reduces the number of slides, it reduces the use of other technique of sampling, shortens the time of the procedure, reduces the risk due to the repeated sampling, and if necessary, it helps to require more material for ancillary study. For instance, another example, you have a lesion, you sample the lesion with the needle, you think this lesion may be a tumor, you look the material at ROSE, and ROSE show inflammatory cells. So maybe it cannot be a tumor, it could be inflammation, it can be an abscess, granuloma, or other things. So this means that I can focus on take more sample for microbiological studies according to the indication that I get from ROSE. Well, ROSE may have advantages even if negative, because induced to repeat sampling, induced to modify or adjust the sampling technique, induced to change the site of punction or the target, or induced to use alternative means of sampling. I have a nodules, I take biopsy transbronchially to the nodule, I look at ROSE, ROSE is negative. I repeat the sampling, ROSE is negative. Maybe this negative may induce me to approach this nodule in another way, for percutaneous way, for instance. And if positive or negative, in any case, ROSE provide feedback, guided strategy that optimizes our procedure and has also an educational value for the bronchoscopist and for the cytopathologist. Well, this is the background. Nevertheless, ROSE is underutilized because several reasons. The first is that there is a lack of pathologists specifically trained and dedicated to cytology. The second is that there is a cultural bias of pathologists. They don't like to leave their offices, and they don't like to come in the bronchoscopic suite. They think that this could be a loss of time, take away from their routine diagnostic activity. And the third point is a problem of cost and reimbursement. There is the lack of adequate reimbursement for cytopathologists in most healthcare systems. So this is the reason why this rose is still gray. Well, what can we do? But the question is really the cytopathologist on site necessary to perform ROSE? What is your answer? Do you have the radiologist on site in your bronchoscopic suite? How many of you have the radiologist on site? Nobody. So, how many radiologists are in the room? No one. How many pulmonologists? And so on. Whole pulmonologists. I ask to the pulmonologist, how many of you are able to evaluate the CT scan on the top of the slide? And so on. There is a nodule on the left, on the right upper lobe. There is a lymph node enlargement on the left paratracheal. I think that all the pulmonologists are able to understand. Yes. Well, how many of pulmonologists are able to understand the two cytological slides below? Hands on. No one? My God. Why? There is one reason why the pulmonologist can evaluate the CT scan and cannot evaluate a cytological slide. Tell me one reason. So, we understand this problem, and we started with a study some years ago. I took a young fellow, 30 years old, and I told him, my friend, go for 3 months in the cytopathology department, practice with the cytopathologist, look at the slides with the cytopathologist, study a book, this book, Pulmonary Cytopathology, it's wonderful. 3 months, very short time. And after 3 months, we started this study. He learned to handling the samples, to smear the material. It's not very difficult to evaluate a cytological slide obtained by transbronchial needle aspiration because the lung is a very simple structure from the morphological point of view. What we need to know is blood cells, red blood cells. It's very easy. I learned to do it. Lymphocytes, macrophage, bronchial cell, a typical pattern, 5 things to learn, 5. Bronchial cells, very easy. There are cilia, you can see the cilia. The nucleus is on the basis. Lymphocytes, nobody don't recognize lymphocyte. Macrophages and a typical cell. ROSI is very cheap. What we need is a microscope. There is a microscope in every hospital. It's very cheap. And the system of rapid stain, we use Hemacolor Merck, but there are other, like Diff Quick or other system, all are okay. Fixing solution on the left, 20 seconds. Color red, 5 seconds. Color blue, 10 seconds. and water. In 30 seconds, you have the slide ready to be evaluated. The total cost, including the microscope, is no more than 3,000 euros. And of course, you need a good and a friendly cytopathologist that must be not jealous of its skill, but it should be available for teaching. Well, we categorize the samples in 5 categories. 5.1 is not diagnostic, C5 is malignant, C1 is not diagnostic. And we start with the study. It's a prospective study. 78 patients underwent 322 samples with conventional TBNA of hilar mediastinal lymph node, and each slide was blindly revised by the young pulmonologist after 3 months of training in cytopathologist, and by the expert professional cytopathologist in blindly. And we did a comparison. And we published the result on CHEST about this study, and this is the result. It's unbelievable. After 3 months of training, the pulmonologist is able to evaluate the rows with the overall concordance, very good concordance, over 80%, 83.5% with the cytopathologist. Keep in mind that if you put together 2 cytopathologists, you obtained more or less this value of concordance. So it's very good results. Some false negative, some false positive, but the conclusion are that rows can be efficiently performed by bronchoscopists after a short training in cytopathology. It's just a problem of culture. We are not used during the study, during the university, during the specialization to learn and to evaluate the slides of cytopathy. Other specialists do it, like hematologists, for instance, that are able to evaluate the slides of blood, or also nephrologists that are able to evaluate the biopsy of kidney. So why pulmonologists don't study basic element of cytopathologists during their training? It's unbelievable. Be careful. Rows performed by bronchoscopy should just assess whether diagnostic set could be present or not. Our job is not to make diagnosis. Even if after some training, my fellow says, oh, this is an adenocarcinoma, this probably is a squamous cell, this is small cell, and every time I say, you must not say what is it. You must just say, yes, this is a diagnostic sample, or not, I have just blood cell, repeat the sample. This is what I need. I don't need diagnosis by you. The meaning of rows performed by bronchoscopy is not to formulate diagnosis, but to have information for the best management of the bronchoscopic procedure. The final evaluation remains the task of cytopathologist, and nothing would be taken away from his competence and his responsibility. The responsibility of the diagnosis is and remain by the cytopathologist. So this means that basic knowledge of cytopathology should be inserted in training program for pulmonologists and should become part of their culture and qualification. We don't need money to do this. Just say, I want to do this. Well, in this way, we can close this circle. To optimize our bronchoscopic procedure, we need to know the clinical data of the patient. Don't perform bronchoscopy without visiting or know what is the pathology, the condition of the patient. We have to evaluate the imaging. Don't perform bronchoscopy without looking at the CT scan of the patient. Of course, we have to manage the bronchoscopic procedure, and the cytopathological evaluation is a whole that we must fill to close the circle and to have all the competencies to perform in the best way a bronchoscopic procedure. Well, you know that the man's dream is to have expensive toys, car, motors, but fun can be obtained also with cheaper toys. And the same is for the pulmonologist. The dream of pulmonologists, of bronchoscopists, is to have expensive tool, electromagnetic navigation, optical coherence tomography, and bronchial ultrasound, everything. But improvement of diagnostic yield may be obtained also with a cheaper tool that has a microscope, less than 3,000 euros. This could be the way to make the rose to flower, to change the color from green to red. Thank you very much.
الرحمن الرحيم. نبدأ الجلسة بعنوان Venous Thromboembolism. The first speaker Professor مدحت عبد الخالق. Professor مدحت هيتكلم على Risk Stratification and Management of Pulmonary Embolism. اتفضل دكتور مدحت.
Thank you, Mr. Chairman. مساء الخير. طبعا انا بعتذر هتلاقوا صوتي اوحش من المعتاد لاني طبعا عندي برد فمعلش. انا بشكر طبعا الكونفرنس كوميتي for inviting me to participate in this meeting. والنهارده هنتكلم على الريسك stratification of pulmonary embolism. يعني مش هنتكلم على الدايجنوزس، هنتكلم على بدايه ريسك stratification of pulmonary embolism. Would you suggest to treat this patient in the outpatient? Male patient, 65 years old, hypertensive, history of 3 days of increased breathlessness and developed worsening of breathlessness in the last 24 hours. Examination, hemodynamically stable, heart rate 90, blood pressure okay, respiratory rate, saturation at oxygen okay, normal heart sound, clear chest, normal abdominal and neurological examination, proved by CTPA to be pulmonary embolism. Would you manage this patient in outpatient? This is the الحقيقة guidelines بتاعت ال European Society of Cardiology still لغاية دلوقتي 2014 valid ومهمة. أول حاجة I would examine the patient, would decide whether it is hemodynamically stable or not. If hemodynamically unstable, I consider him as high risk, and this is solve itself. If hemodynamically stable, I have to do some prognostic tests, clinical parameter, imaging of the right side, echo and CTPA, biomarkers of the right ventricular dysfunction like NT-pro, BNP, biomarkers of right ventricular myocardial injury like the troponin and the other lab finding. الحقيقة زمان كنا بنعمل في السكورينج سيستم many system موجودة، جنيفا، ويلز، بيتزا and so on. الحقيقة في الآخر خالص استقرينا على أن يعملوا حاجة اسمها PC اللي هي pulmonary embolism severity index، ودي كانت بتتكون من 11 ايتمز كل واحد بتاخد، وفي الاخر لازم تكون حوالي 75، وبنقول كلاس 1 اللي هو عند 65 وكلاس 5 اكتر من 125. لكن وجدنا برضو ان البي سي از a little bit complicated، وعملوا حاجه اسمها اس بي سي اللي هي simplified بي سي اللي هي عملوا 6 ايتمز بس. فيري ايزي انك تشوفها. الايدج، واذا كان هيستوري اوف كانسر، كارديو بالمونري، البلاد بريشر، البالس والساتوريشن. ودي نيجاتيف. لو بوزيتيف بعتبر دون اللي هو انترميديت ريسك. اتس فيري ايزي ذان ذا وعشان كده دلوقتي كلنا بنستعمل الاس بي زي. طبعا دي النورمال، والنورمال الاس بي زي اللي هي طبعا تطلع زيرو او نيجاتيف. وجدوا انه طبعا اللي هو الزيرو اس بي سي هي تقريبا بتساوي كلاس 1 اند 2. لكن دلوقتي خلاص بكل كلامنا بنتكلم على الاس بي سي. اتس فيري ايزي. 6 ايتمز، لا اما زيرو لا اما اكتر من واحد، واتس فيري ايزي. في another parameter very important اللي هي when I'm going to admit the patient. هعالج البيشنت اوت بيشنت ولا هدخله. دي اللي بنسميها هيستيا كرايتيريا. وهنا في 11 questions. If any answer of this question yes, I have to admit the patient. يبقى عندي 11 questions. لو الانسر yes, I have to admit this patient. If the patient hemodynamic unstable, I will admit. Indication for thrombolysis or embolectomy, I have to admit. Bleeding or risk of bleeding like recent operation, recent stroke, bleeding peptic ulcer or anything, I have to admit. Oxygenation, hypoxia instead of oxygen therapy, I have to admit. Already on anticoagulation, I have to admit. محتاج intravenous medication, I have to admit. عنده malignancy, عنده renal impairment, liver impairment, pregnant, I have to admit. العيان ده كان اخذ قبل كده هيبرين، و كان عنده هيت اللي بنسميه هيبرين انديوس ثرومبوسايتوبينيا. I have to admit. يبقى عندي 11 question. Any question اجابته yes, I have to admit this patient. ده comparison between الاس بي سي and هيستيا to admit the patient. نرجع تاني للجايد لاينز بتاعتنا. زي ما قلنا لو unstable يبقى ده هاي ريسك، لو بي سي زيرو يبقى ده لو ريسك، لو اللي هو طلع بي سي اكتر من واحد او سمبليفايد بي سي اكتر من واحد او بي سي 3 او 4 هنا بعتبره انترميديت. وفي الحاله دي بعمل حاجتين: باسس الرايت فنتريكل باي ايكو اند سي تي بي اي اند رايت فنتريكولار فانكشن ديسفانكشن اند انجري باي ذا ماركرز، واشوف لو واحده بس افكتد، لو الرايت سايد ايمجز افكتد او بايو ماركرز بعتبره انها انترميديت لو. لو بوث افكتد الرايت فنتريكل اند بايو ماركر بعتبره انترميديت هاي. يبقى انا هنا بنتهي بالستراتيفيكيشن اوف ذوز بيشنتس انتو 4 categories: low risk patient, high risk patient ده قلنا اللي هو unstable, and intermediate patient which is intermediate low, only one item affected, و intermediate high, both the biomarkers and the right ventricular dysfunction are affected. دي الايكو اللي بقدر اقرا بيها although it's not non-sensitive، لكن بقدر I can diagnose بيها right ventricular dysfunction لو لقيت الرايت تو ليفت diastolic end-diastolic volume اكتر من واحد، flattening of interventricular septum, hypokinesia of the free right ventricle. بنلاقي الليفت ventricle بيتحرك والرايت ventricle اللي هي بنسميها باكالان ساين، دي بقول عليها ان في رايت ventricular dysfunction. التبس تبقى اقل من 16 او distended inferior vena cava. لكن الحقيقه السي تي بي اي مور اكيوريت نسبيا عن الايكو. لو وجدت برضو في السي تي ان الرايت تو ليفت ventricle اكتر من واحد، او في flattening or bowing of the interventricular septum، او في ريفلكس اوف ذا داي انتو انفيرو فينا كيفا، او الثرومبس تبقى لودنج وانا بعمل الدايناميك. دي كلها بيقولوا ان في رايت فنتريكولار افكشن. دي كمان البريتش ثوراسيك سوسايتي نفس تقريبا الجايد لاينز، بس هنا اقسمها لو هستعمل هيستيا وهستعمل الاس بي سي. طبعا لو هو كونفيرمد ان هو عنده بالمونري امبوليزم، وبعد كده بسال نفسي ال 11 سؤال بتوع الهيستيا. لو اني وان فيها بوزيتيف يعني يس شود ادميت immediately. لو نيجاتيف بعمل الرايت فنتريكل والبايو ماركرز. لو البايو ماركرز بوزيتيف I have to admit. لو البايو ماركرز مش بوزيتيف واونلي رايت فنتريكل I have to assess. لو هو intermediate I admit for 1 or 2 days. لو لا يبقى ده low and I have to discharge the patient and give outpatient treatment. لو هستعمل ال simplified PC the same نفس تقريبا اللي احنا قلناه في الهيستيا. كده خلصنا الريسك ستراتيفيكيشن. وات ار ذا ام جوينج تو جيف ذا بيشنت. طبعا التراديشن واللي اتعلمناه من زمان اللي هو كنا بندي بارنترال هيبارين، وبعد كده بنسويتش تو اورال فيتامين كي انتاجونست. زمان ايام زمان ما كنت نايم من 200 سنه كنا بندي اليو اف اتش طبعا، وكنا بندي تملي 80 يونت بولس، وبعد كده 18 يونت بير كي جي بير اور بالانفيوجن. طبعا بطلنا نعمل الكلام ده، والمحطه اللي بعد كده كنا بنستعمل اللو مولكولار ويت هيبارين مع الفيتامين كي انداجنوس لمده 5 ايام، وبعد كده بوقف اللو مولكولار هيبارين وبكمل بالفيتامين كي انتاجونست. وممكن تبقى لونج تيرم اللي هي لغايه 6 شهور، او اكستندد ممكن اديها اكتر من 6 شهور، او فور لايف لو الكوز او البريسبوزنج فاكتورز فور في تي اي از بيرزيستنت اور وات وي كول ات unprovoked بالمونري امبوليزم اللي انا مش عارف الكوز، او اللي عنده بيرزيستنت كوز اللي عمله زي عنده ثرومبوفيليا، فده بديله فور لايف. كده بيديني ان انا عندي 3 ميثود اوف ادمنستريشن اوف انتي كواجوليشن. ايذر اللي تحت خالص، معلش البتاع مش شغاله، الشغل ده البريدجنج ده اللي كلنا عارفينه وبنستعمله، وفي سويتشنج وفي سنجل انتي كواجوليشن. البريدجنج اللي كلنا بنستعمله وكنا بنستعمله زمان وتعلمنا عليه اللي هو اللو مولكولار ويت هيبرين والفيتامين كي انتاجونست لمده 5 ايام، وبعدين بوقفه وبكمل باللو مولكولار ويت هيبرين. السويتشنج ده 2 دراجز اونلي، الدابيجاتران اللي هو اسمه بروداكسا كلكم عارفينه، ودوكسابان. ممكن ان انا ابتدي باللو مولكولار ويت هيبرين وبعدين بكمل بيهم، عشان كده بنقول سويتشنج. ليه بنعمل هذا الكلام؟ لان الاثنين دول زي الفيتامين كي they don't affect بروتين سي، بالعكس بيزودوه. فممكن لو انا ما ابتديتش من الاول اللو مولكولار ويت هيبرين العيان ده يحصل له ثرومبوز. انما يفضل عندي التو الحقيقه دراجز اللي احنا بنستعملهم دلوقتي اللي هم الريفاروكسابان اللي هو اسمه زاريلتو عندنا في مصر، والابيكسابان اللي هو الاليكويس. دول بستارت فروم ذا ستارت اوف ذا تريتمنت على طول، عشان كده بسميها سنجل اورال تريتمنت. هو ده اللي بنستعمله كلنا دلوقتي طبعا في اللو ريسك بيشنت. طبعا بالنسبه للريفاروكسابان بنستعمل 15 ملغ توايس ديلي لمده 3 اسابيع، وبعد كده بسويتش تو 20 ملغ وانس ديلي. لكن لو العيان كان عنده هاي ريسك اوف بليدنج اي كان ريديوس دوز تو 10 ملغ بير داي. بالنسبه للاليكويس او الابيكسابان بدي التابلت فيها 5، بدي 2 تابلت كل 12 ساعه لمده اسبوع، وبعد كده بقى شيفت 1 في 2. لو العيان عنده بلينج تندنسي بريديوز الدوز ل 2.5. يبقى دي الميثود اوف ادمنستريشن اوف انتي كواجليشن للعيان طبعا اللي مش لايف ثريتنينج، العيان اللي هنتكلم عليه بعد كده اللي هو طبعا بريدجنج وسويتشنج اند سنجل اورال يوز. الحقيقه عشان كده احنا بنهتم دلوقتي بالسنجل اورال يوز. وعندنا بالنسبه للريفاروكسابان والابيكسابان عشان سهوله اخدهم كان في 2 مين ستاديز مشهورين جدا، طبعا همر عليهم بسرعه لان كلكم عارفينهم، اللي هم الاينشتاين دي في تي واينشتاين بالمونري امبوليزم. ده بالنسبه للريفاروكسابان. وعندي الامبليفاي والامبليفاي اكستند دي بالنسبه للابيكسابان. الاثنين ستادي دول اتعملوا على مالتي سنتر ستادي بيج ستادي، وتقريبا طلعوا نفس النتائج بتاعتهم، ان سواء كان الابيكسا او الريفاروكسابان not inferior as efficiency. نمبر 2 البليدنج تندنس بتاعتهم الريسك اوف بليدنج less than the vitamin K combination of vitamin K and low molecular weight. الهوسبيتال ستاي اقل والميجور سايد افكتس اقل. عشان كده دي طبعا ستادي الامبليفاي ستادي، ودي همشي عليها بسرعه، دي موجوده في النت اي حد عايز يدخل عليها. دي الامبليفاي ستادي بتاعت الابيكسابان زي ما انتم شايفين ان هو، ودي الاينشتاين ستادي اللي هي بتاعت الريفاروكسابان اللي هو اسمه زاريلتو عندنا. طبعا كان نون انفيريور وكان البليدنج تندنسي اقل من اللو مولكولار ويت هيبارين. مش كده وبس، ده هم لما استعملنا الاورال ذا ريفاروكسابان مع الديفرنت جريدز اوف ريسك كان الريكارنس اقل من التراديشنال، وكان الميجور بليدنج اقل. لكن فضلت حاجه تملي كانت موجوده، والتملي هي كونتروفيرسي. طب انا ما عنديش انتي دوت، هدي ازاي الدواء ده ممكن يحصل لي عنده بليدنج؟ انا عندي في الهيبارين انتي دوت، وعندي في الفيتامين كي انداكونست انتي دوت. طب انا هدي العيان ويحصل له بليدنج واحتاز بيه؟ ريسنتلي من فيو مانثس اجو الاف دي ابروفد طبعا انتي دوت فور الريفاروكسابان اند ابيكسابان اللي هو اندكسانات الفا او الاندكسا. ده كان ريفيرس the anticoagulation effect of activated factor 10 اللي هم الريفاروكسابان والابيكسابان. فبقى عندي دلوقتي انتيدوت للاورال اللي بنسميها دواك، كنا زمان بنسميها نواك بالان، يعني نوفل اورال انتي كواجولانت. طبعا ما عادتش نوفل، ما عادتش حديثه، بنسميها دلوقتي دواك بالدي، يعني دايركت اورال انتي كواجوليشن. ودلوقتي بقى في انتيدوت. طبعا الانتيدوت اللي انت عندك لو انت بتدي جرعه صغيره، يعني الريفا اقل من 10 والابيكس اقل من 5، بتدي 400 مللي جرام بولس، وبعد كده تدي 4 مللي جرام بير مينيت لمده ساعتين. لو انت بتدي الجرعه بتاعتنا العاليه تدي 800 مللي جرام بولس، وتدي بعد كده 8 مللي جرام بير مينيت لمده 120 مينيت. طبعا من 2015 كان الاف اي دي ابروفد الانتي دوت بتاع الدباجاتران اللي هو البرادكسا، اللي هو طبعا مونوكلونال انتي بودي. ده موجود من 2000. لكن دلوقتي انا عندي انتي دوت للدواك، يبقى كده انا ما عنديش حجه، عندي دراج اتس فيري ايزي تو ادمنستر فروم ذا ستارت اوف ذا diagnosis اوف بالمونري امبوليزم. ما فيش انتر اكشن مع اذر دراجز، ما فيش انتر اكشن مع فود، مفيش فولو اب واضطر اعمل معمل والاي ان ار تنقص وتزيد والكلام ده كله. وفي نفس الوقت عندي الانتيدوت، فده كله بيسبورت ذا يوز اوف ذا دواك ان ذا مانجمنت اوف ذا زي ما قلنا اللو جريد بالمونري امبوليزم. الكانسر بس كان لغايه قريب، لغايه فيو مانثs اجو، كان بيقولوا ما تستعملش خالص الدواك في عيان كانسر اسوشيتد ثرومبوزيس. الحقيقه لا، ريسنتلي قالوا لا استعملوه، ما عدا في حاله واحده بس اللي هو جي اي تي كانسر، لانه وجدوا ان هو البليدنج تندنسي بتزيد مع الجي اي تي كانسر اللي انا استعملت دواك. يبقى انا ممكن استعمل الدواك الريفا والابيكسابان مع كانسر اسوشيتد ثرومبوزيس اكسبت ان ذا جي اي تي كانسر. هنا زي الجايد لاينز، انت هنا في الاخر بقى عندنا لو وانترميديت لو، انترميديت هاي اند هاي ريسك بيشنت. طبعا اللو هعالجه في الاوت بيشنت، هكتب له الريفاروكسابان او اكتب له الابيكسابان، وبعد كده هفولو هذا العيان في الاوت بيشنت كلينيك. بالنسبه للانترميديت هدخله 48 ساعه وفولو، لو ما حصلوش حاجه هخرجه برضه على الاورال انتي اللي هو الدواك. نيجي عندنا الانترميديت هاي اللي هو عنده حاجتين، الرايت فنتريكل ديسفانكشن والبايو ماركر، وطبعا الهاي اللي هو في شوك. طبعا الاثنين دول هيخشوا الرعايه المركزه. بالنسبه للانترميديت هدخله الرعايه المركزه واعمل له مونيتورنج واشوف لو ديتيريوريتد هعمل له وات وي كولد اللي هنشوفه بعد كده ريبرفيوجن مانجمنت. طبعا بالنسبه للي هو الهاي ريسك بيشنت ده هدخله على طول الاي سي يو، ده هاف life threatening pulmonary embolism and should be admitted to the ICU وبتستارت على طول immediately reperfusion management. يبقى انا الاثنين الاخرين دول انا حاجه what's called life threatening pulmonary embolism. ايه هو life threatening pulmonary embolism؟ اللي هو السيستوليك بلاد بريشر اقل من 90 او العيان داخل، عشان كده بنقول لك حطه اندر مونيتورنج الانترميديت. لو العيان حصل sudden drop in the pulmonary pressure systolic pulmonary pressure more than 40 in quarter في اور، يعني في ربع ساعه العيان مثلا كان 140 130 ولقيته بعد ربع ساعه بقى 100، لسه مش شوكد، ما اقل من 90، لكن الرابيد ديكلاين في السيستوليك بلاد بريشر شود على طول alert you it is life threatening pulmonary embolism. هعمل ايه؟ طبعا دي الميكانيزم كلكم عارفينها، همشي عليها بسرعه. ازاي بيحصل الافكشن اوف ذا رايت سايد؟ من اول طبعا انكريز اللود على الرايت فنتريكل نيورو هرمونال، وديكريز الديمانت اوف اوكسجين واسكيميا، وفي الاخر ينتهي عندي العيان دون بشوك. مش هدخل فيها قوي. العيان ده هعمل له ايه؟ طبعا زي اي عيان في الدنيا بيخش كريتيكالي ال، يبقى لازم اعمل جنرال ميجرز للعيان دون. بعد كده بفكر ادي سيستميك ثرومبولايسيس، بعد كده كاستر دايركتد ثيرابي، وفي الاخر بلجا لفينو ارتيريال اكمو. دي اللي هي جنرال مانجمنت اللي كلكم بتعملوها، اللي فيكم بيشتغلوا اي سي يو. لما بيخش واحد كريتيكالي ال وابتدى يخش يبقى هيمو دايناميكالي انستيبل، بتبتدي تعمل الحاجات دي تاسس طبعا جنرالي. بعد كده تايدنتيفاي ريجرينج فاكتورز، تو اوبتمايز الفلويد، اركب طبعا سي في بي واوبتمايز الفلويد بتاع العيان ده عشان ما يبقاش اوفرلودد ولا يبقى ديهايدريتد، واشوف الفلويد بتاعه. بدي طبعا انوتروب، واهمهم طبعا النور ابنفرين او الليفوفيد، وبكمل باذر انوتروب. لو العيان ده ما تحسنش مع الانوتروبس احاول ادي دراج يدي رابيد ديكلاين ان ذا بالمونري هايبرتنشن. لو عندك ناتريك اوكسايد انهاليشن موجوده في الرعايه ادي، او ادي بروستاسايكلين باي انترافينوس تو ديكريز ذا بالمونري هايبرتنشن اللي حصل suddenly مع اللايف ثريتنينج بالمونر امبوليزم عشان تافويد الشوك وتافويد الديث اوف ذا بيشنت. الثرومبولايسيس طبعا كلنا اعتقد لنا خبره بيه. كان زي ما بيقولوا في اول 48 ساعه كل ما كان بدري كل ما كان احسن، لكن لغايه 14 يوم ممكن يفكت، لكن 90% من العيانين كان ريسبوند ان ذا فيرست 38 hours. لكن الهيموديناميك افكت the earlier you use the thrombotic the thrombolysis the better. هنستعمل ايه؟ كلنا برضو الحاجات التراديشنال ابتدينا بيها اللي هو ستريبتوكاينيز، وكنا كلنا بنستعمل الجرعه اللي هي 250,000 انترناشونال يونت بنديها على مدى نص ساعه، وبعد كده بندي 100,000 انترناشونال يونت كل ساعه لمده 24 ساعه. او الواحد لو مستعجل شويه ممكن يدي على طول 1.5 مليون على مدى ساعتين. لكن هو الحقيقه المدرسه الاولانيه اللي كنا بنستعملها برضو بطلنا دلوقتي بنستعملها، وبنستعمل التي بي اي التيشو بلازمينوجين اكتيفيتور، وده بنستعمله اللي هو 100 مللي جرام بنستعمله اوفر 2 hours. لو انت مستعجل قوي وخايف قوي ممكن تستعمل حوالي في ربع ساعه، بس ما تزودش عن 40 مللي جرام. هو 6 من 10 مللي جرام بير كي جي، لو اعتبرنا ان هو 70 يعني تقريبا هتبقى 40 مللي جرام، ما تزودش هذا، ده تنزله في ربع ساعه. دي الثرومبوليتيك اللي احنا بنستعمله دلوقتي الحقيقه التي بي اي. ما لناش طبعا اي خبره باليوروكاينيز وما عمرناش استعملناه في مصر خالص. دي الجايد لاينز مش هضيع وقت فيك، موجوده طبعا كلها بتاعت اوروبيان. هي بس ان انت عيان الانترميديات هاي ما تبتديش معاه الثرومبولايسيس لان في كونتروفيرسيز، الا لو لقيت العيان داخل في شوك منك وكده ابتدي معاه الثرومبولايسيس، لكن لقيته ماشي كويس ممكن تمشي كويس معاه. دي الحقيقه كاستر دايركتد ثرومبولايسيس، همشي فيها بسرعه لاني ماليش فيها خبره وعمريش عملتها، انما هي طبعا ميثود اوف intervention to deal with life-threatening pulmonary embolism. ممكن اخش بالكاستر دايركتد اعمل فريجمنتيشن اكسرها واطلع بيها، او اغير السيرفيس تنشن بتاع، طبعا هي لو فريش لسه، واشيلها بالكاستر، او سكشن بالسكشن، او الثالثه بعملها روتيشنال عامله زي الشنيور كده واشيلها بيه. دي صوره الكاستر دايركتد ثرومبولايسيس اللي هي الترا ساوند جايدد. زي ما قلت لكم انا ماليش خبره وما اعتقدش في مصر بتتعمل. العيان اللي انا كملت معاه زي ما قلنا قبل كده ووصلنا معاه لغايه ادينا له الحاجات كلها اب تو، ادينا له البروستاسايكلين وانهيل كورتيكوستيرويد، وحاولنا ندخل بقسطره والكلام ده كله. العيان ابتدى يتعب وكده، العيان ده هنحطه على ميكانيكال فنتليشن ونعمل له اكمو. ايه هو الانديكيشن اوف اكمو؟ العيان ارست على البختك وانت رايح له، العيان ده كاردياك ارست على طول، طبعا ما فيهاش فصال، هات انتيوبيت تحطه على ميكانيكال فنتليشن ويبقى فينو ارتيريال اكمو. العيان ده عنده سيفير هيمودايناميك كومبرومايز اباوت تو ارست، هو لسه ما حصلش ارست انما بوتنشال ارست ده يخش في براديكارديا وابتدت الدنيا تبوظ معاك، على طول هتحطه على ميكانيكال فنتليشن فور اكمو. كونتر انديكيشن ثرومبولايسيس، العيان ده عنده ريسنت ستروك، عنده ريسنت اوبريشن، بليدنج بيبتيك ألسر، هيماتوريا بتاع، خلاص يبقى انا كده من الاول احطه على ميكانيكال فنتليشن واستارت فيلد او فيلد الثرومبولايسيس او فيلد القسطره لو انت عملت القسطره، او البيشنت بقى سيفير هايبوكسيميك وخلاص، فبحطه على فنتليتر وابتدي معاه الاكمو. دي طبعا الاكمو اللي بنعملها ما عندناش احنا في الوحده، انها موجوده في وحده الاي سي يو في القصر العيني، الدكتوره علي عبد الفتاح بتعملها، وعملنا كذا حاله، وفي ناس دلوقتي من الدكاتره عندهم بورتابل اكمو بيقدروا يروح المكان ويعملوا البورتابل اكمو. دي الاكمو اكسترا كوربوريال اكسجين اكستراكشن، وهو العيان على ميكانيكال فنتليشن. في كل اي مستشفى واي سنتر ومعنا طبعا دكتور اسلام هنا طبعا من سنتر محترم من سان دييجو، بيبقى في تيم تو دو امرجنسي. يعني عندي ارست تيم، ارست تيم يعني ايه؟ يعني اول ما يطلع له على البتاع بلو كود في الحته الفلانيه يجري التيم يعمل السي بي ار لهذا العيان ويحاول ان هو يعمل هذا العيان. في نفس الموضوع بالظبط حاولوا يعملوا تيم لللايف ثريتنينج بالمونري امبوليزم اللي هم سموه بيرت، اللي هو بالمونري امبوليزم ريسبونس تيم. ان هم التيم دون اول ما يجي لهم خبر ان عندي دلوقتي لايف ثريتنينج بالمونري امبوليزم يجري التيم دون ويعمل الحاجات اللي احنا اتفقنا عليها. التيم ده بيتكون من كارديولوجيست، من بالمونولوجيست، من كاردياك سيرجن، هيماتولوجي، راديولوجي، انستيزيا طبعا عشان اتدخلت، طبعا لو هي فيميل وبريجننت يكون معاهم جاينيكولوجي. والتيم ده اول ما يجي لهم على طول ان عندي لايف ثريتنينج بالمونري امبوليزم يجري التيم ده اللي احنا اتكلمنا عليه، ويفكر هو مع بعضيه بسرعه هعمل ايه؟ هدي ثرومبولايسيس، ولا هخش على طول افتح واعمل امبليوكتومي الجراح يعني، ولا هعمل كاستر دايركتد ثرومبكتومي، ولا العيان دون اباوت تو ارست وخلاص واحطه على فنتليتور واعمل اكمو. يبقى البير تيم دون بسرعه هيقرر يعمل لي حاجه من الحاجات دي اللي بيها وهو كان سيف ذا لايف ثريتنينج بالمونري امبوليزم. This is my last slide. Summarize my talk. The certification of the risk of pulmonary embolism according to clinically to two SPC and HISTA, and after that you have to do right ventricular assessment and biomarkers, and if patient shocked and life-threatening, you have to interfere. According to a certification, you have to decide to treat the patient at home, to treat hospitalized for short period of time, low intermediate risk patient, or to admit to the ICU high or intermediate or high risk patient and go into reperfusion therapy. Thank you. I appreciate your attention. Thank you.
بسم الله الرحمن الرحيم. شكرا جزيلا لاستاذنا دكتور مدحت عبد الخالق على المحاضره القيمه. ودلوقتي هندعو الاستاذ الدكتور اسلام ابراهيم نتكلم على clinical puzzle can you get to the diagnosis in interactive case.
Assalamu alaikum. Let me first start by thanking the Society for the invitation to speak. It's a great honor to be here. And I have a case for you, and I'm hoping that the audience will help me make the diagnosis. Do we agree? Are you with me? All right. Well, the presentation is going to be unorthodox. The way we're going to present the case, I'll give you a few slides, and then I will ask the audience what test you'd like to get next. So be prepared, okay? So I present to you a real case from UCSD, although most of the work was done outside of UCSD. And like they say in the movies, based on a true story, but the producer sometimes plays with the scenario to make it more fun. So for the next 20 minutes, I hope we're going to have to make this into a fun session. Okay, you agree? All right, so let me advance and introduce my patient to you. And if I can get that to work. Okay, here is my friend Jose Rodriguez, and he is from, let me advance from here. He is from Mexico, visiting the United States on July 2nd, 2019. Pay attention to the dates, because that's important. And he presents to a clinic in the States with the following complaints. I didn't write any words on the slide. I wanted to guess what he's complaining about. Well, obviously he is short of breath, he is sweating, he is tired, fatigued, and he's also coughing something that looks like that. All right? Now, a week earlier, he flew from Mexico to Denver, Colorado, to visit some friends. When he landed, he developed upper respiratory tract infection symptoms, followed by the dyspnea, the exertion, and the cough and the sputum that you've seen. When we obtained further history, he said that for the past 5 months, since February, he's been feeling more lethargic, fatigued, and his exercise tolerance has been dropping. In family history, not very helpful. His father is diabetic, his mother is hypertensive, both grandparents had acute MI. But he's been a bad boy. He smokes like a chimney, 40-pack year history of smoking. He drinks beer every day, 6 of those beers. And even worse, he smokes methamphetamine. He both injects it intravenously and also smokes it. And you know what methamphetamine can do to the lungs and the heart. In 2009, he was working in demolishing houses in Mexico, and he got exposed to asbestos. He also worked as a machinist in a factory, and he was exposed to hard metal. He was in jail for 5 months in 2017. I'm not going to tell you why he went to jail, but he was. And his travel history is significant for Colorado, where he is visiting friends, and Mexico, where he lives. I finished my history here, and on physical examination, I'm concerned that he's a bit tachycardic, a bit tachypnic, and a bit hypoxemic. And I say, Jose, by the way, I tried to get one of the volunteers to play Jose with me. Nobody wanted to come. The only one who volunteered said he wants $500 to play Jose. So I couldn't get you an actor. So let's pretend that Jose is here, and I'm talking to Jose. I say, Jose, I'm concerned about your heart rate being too fast, about your respiratory rate being fast, about your oxygenation. I want you to go to the hospital, Jose. And Jose is from Mexico. He doesn't have insurance, doesn't have money, does not want to go to the hospital. So Jose says no. He is on exam tachypnic, diminished breath sounds. He has a little bit of pedal edema, just a trace on the ankles on both sides. Nothing much on exam, not very helpful. And I say, Jose, go to the hospital. And he says in his Spanish language, no bueno, mucho dinero. That's a lot of money, and it's not good. All right, so we do some laps nearby the office, and I see a little bit of leukocytosis, nothing impressive. Differential is unremarkable, as you see. We also get some extra laps, and I see that his kidney is not perfect. His creatinine is 1.4. He has a baseline renal insufficiency. And his liver enzymes just reflect his drinking history, so nothing big there either. And we're still on July 2nd. Now, we also get HIV testing, negative, procalcitonin, negative, so most likely not a bacterial infection. Well, he had a viral infection, we know that. July 2nd, we get a chest x-ray, right-sided pleural effusion, as you can see. I'm done with my presentation. The rest is up to you. Now, I'm gonna do something interesting here. And I get to see all the slides, and you don't. So here I'm telling Jose one more time, Jose, you need to go to the hospital, and Jose is saying, absolutely not, he's not listening to me. This is when I turn to you to tell me, what's your differential diagnosis? What does he have? Any volunteers? I guess the list is long. You can guess anything, and you'll be right. But I'm gonna help you out. You want to say something? Yes. Okay. Okay. Good reasoning. Okay, good reasoning. Although I would say 10 years exposure to asbestos is too short. You need at least 25 years or 30 years to get asbestosis and mesothelioma and stuff. So I would say it's a little short. But I'm going to help you here. And for the sake of time also, do you agree, as audience, raise your hands if you agree with me. Could this be a pulmonary infectious etiology? Yes or no? Raise your hands if you say yes. Very nice. And I agree with you. Could this be non-infectious inflammatory disease? Like what? Rheumatologic, vasculitides, GPA, EGPA. There's nothing in the history to support that, right? So I'll give it like a gray color, which is not highly likely. Would you agree this could be cardiac? Agree. Neoplastic? Smoker? Smoker. 40-pack year history smoking, and now he's coughing up blood. You agree? Show me hands. Neoplastic? Okay, good. You agree. Could this be occupational-related exposure? Worked in a factory, asbestos, like he said. Could it be? At least the baseline, shortness of breath. Could it be drug-induced? Methamphetamine, sure. Diffuse alveolar hemorrhage. Could it be allergic? Hypersensitivity, pneumonitis, or something? There's nothing in the history to point to that. Could it be vascular? Okay, we're in a vascular session, so everybody's going to say yes. Okay, could it be idiopathic, COP, or something? Sure, everything is possible. Thank you for helping me with the differential diagnosis. Now, what is the next step? What investigations would you order next? Jose is still sitting in the office. Okay, and I have a pen and a paper. Whatever you ask me to do, I will take notes. So what test? Samra. CT angio. All right. CT angio. I got that down. What else? Echocardiogram. Great. Tapping of the pleural effusion. Great. What else? I wrote all that down. Chest ultrasound. Great. What else? All right. I'm going to work on your orders. And you requested an echocardiogram, and I'm calling Steve, my good friend from the echocardiogram lab, and I say I have my friend Jose, who's not feeling very well. Can you please get him in for echocardiogram? And he tells me, according to my notes, the earliest he can be in is July 8th, which is a Monday. That's real life case. It's not like you want an echo and it pops up like that, especially the guy has no insurance. All right, so we are scheduled for an echo on the 8th. That's 6 days away from now. Do you want to do anything else in between? And somebody wanted a CAT scan, right? So I'm calling the hospital. Hello, this is CT. I have a friend of mine. I'm going to send in for a CT. And they give me a date also, the 8th, which is a Monday. So maybe we can do the echo, and then he can swing by the CAT scan and get the CAT scan done the same day. Okay, very good. I'm going to ask the hospital to do an ultrasound as well. And it's all scheduled for the 8th of July. Do you guys want to do anything between now and the 8th of July? Cardiac biomarkers, exactly, troponins. On that slide, his troponin was normal. Yeah, if I want to go back to the slide, I will show you that it was this slide here that showed, I'm sorry, oh, I took it off. I'm sorry. It was there, but I took it off. D-dimers, very good. Sputum cultures, okay, you're still thinking about an infection. Huh? Blood gases, very good. But it all depends on Jose eventually, right? We want to do a lot of testing. And every time I tell Jose he has to do something, he repeats the phrase, that's why I needed the actor, but he didn't come. He says, no bueno, mucho dinero. So we have to be conscious of the cost. He doesn't have insurance. He doesn't want to spend $1 million on the investigations. Can you think of one test that will give you the answer without spending a lot of money? Bleeding profile? Clotting time, okay. So coagulation workup. All right, so this is what happens. Let me tell you what happened to Jose. Nobody told me that he's a smoker and I'm worried about COPD. The shortness of breath might be because of airway disease. No? No takers? Nobody wants PFTs? Nobody wants PFTs? Okay, all right. So if nobody wants pleural pulmonary functions, I'm not going to show it. But it's there. Nobody wants it. Okay, well, so skip. So echocardiogram, July 8th, I call with the results. Guess what? Jose never showed up. It's a no-show. And we say, well, maybe he's busy getting the CAT scan. Let's not judge him. We call the CAT scan. Jose didn't show up. So I'm sorry, but you're going to have to wait on those results. Well, meanwhile, Jose shows up in the emergency department on July 11th because he was more short of breath. And I get a call from the ER physician saying, your patient is here, he's short of breath. We managed to do an ultrasound of his chest. We found this effusion, and you know, when we find fluid, what do? Put a needle in, and that's what they did. But it is simple, transudative effusion. Nothing spicy there. So, simple fluid. We expected an exudate, right? Because we thought it's either going to be cancer, it's going to be infection, it's going to be PE or something. But it's transudative, to our surprise. What happens next? Jose feels better after the fluid is taken out, and he doesn't want to go to the hospital, so he goes back home. And he calls the office on Sunday, July 14th, saying, "Doctor, I'm coughing up more blood and I'm worried now." And I say, "Jose, it's Sunday. I don't know what to do for you. You need to go to the hospital." And Jose says, "What?" What does he say? "No bueno. Mucho dinero." So I say, "Well, come into the office next thing in the morning." And he does. And as a knee reflex for pulmonologists, when there is blood out of the airway, what do? We'll look in the airway. So I'm looking to see where the blood is coming from. And the results, airways are patent. There are no masses. BAL is not hemorrhagic. It's just a little bit of blood staining the mucosa. No foamy cells, no lipoid pneumonia, no eosinophilia. White count is only 57, 300 red cells, normal differential, cytology negative, microbiology workup is negative. At least we know something. We know my suspicion for cancer is less, suspicion for masses is less. So, but we still have not made a diagnosis yet, right? Are you with me? Okay, let's see what we're gonna do next. On the 17th of July, Jose feels worse. His friends are now worried. They call the ambulance and they ship him to the hospital. At the hospital, Jose has these vital signs. He's now exhausted. He's becoming hypotensive, more tachycardic, more tachypnic, more hypoxemic. And then they say, "Jose, you're coming into the hospital." And no bueno is not gonna work. So Jose is admitted to the hospital. Now he's in the hospital under your control. What test did you guys want? Yeah, CT angio and echocardiogram and ABG, and nobody mentioned the ECG. It's something that we do routinely, right? I think it's useful. Let's look at his ECG because that's the next slide. So here's an ECG, and here is a larger picture of the ECG. Can someone tell me what's going on? Very good. Huh? Okay. 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 Right atrium. Okay. Right. Okay, very good. These are very good comments. And I'll show you all these things that tell me that the right side of his heart is in trouble. There's RV hypertrophy or dilatation, there's big RA, and there is right axis deviation. So there's something happening on the right side of the heart. Okay, we get an ABG, and he is 747, 30, 64, 21. The guy is hypoxemic. If you calculate his AA gradient, it's about 48. And that's why he's breathing fast. He's tachypnic, making himself alcoholic, breathing down his CO2 to 30. All right, and here is the long-awaited echocardiogram. What do we see? Yeah, the right side is dilated. Right ventricle is big, right atrium is big, and the septum is shifted all the way, compressing that left ventricle. I think that's why he's becoming hypotensive, that there is intraventricular dependence, and then the septum is shifted, squeezing the left ventricle, which is not filling well. So it's not going to be pumping well if it doesn't fill up. So it's very tricky when patients like this present with hypotension. The first thing we do is what? Hypotensive patients, we give what? Fluids. But in this case, it could be detrimental because more fluids means more RV ballooning. And that can shift the septum more and squeeze and choke the left ventricle. So inotropes and diuretics, probably a better way to go. Okay, what is the next test? So you got your echo, you got your ABG. What else did you want? CT angio. Let me see if CT angio is the next study. There you go. Now mystery solved. We have this big major filling defect. Can you see it when I use the mouse? Okay. So you see the big filling defect? Okay, so what's your diagnosis? Why is Jose short of breath and coughing up blood, and what does he have? Okay, big pulmonary embolism. At least we say filling defect in the pulmonary artery. Let's say that, okay? Okay, so what's the next study? I guess, a couple more views to show you the extent of his pulmonary pathology. Now, the question next is, would you thrombolize? Yes or no? Show me hands. Yes? All in favor? Thrombolytics? Guy's very short of breath. He's getting hypotensive. Yes, he's going to die if we don't do something. And the answer is yes, agree. And he does get TPA, 100 milligrams, followed by Lovenox, 1 milligram per kg subcutaneously. Today is July 17th, right? He came to the hospital. July 18th, 19th, 20th, and now it's July 21st, and he's feeling much better. He's going home on apixaban. No? Yes? Huh? Okay, what is the reason? Okay, well, we thought he had acute pulmonary embolism. We thrombolized him. We anticoagulated him. He did well. He feels better. He's going home. He's going to be continued on anticoagulation. What's wrong with that plan? Why he developed a PE? Well, he was on a plane from Mexico to Colorado. That's about a 4-hour flight. DVT had a little bit of pitting edema. We don't know. Drugs caused hypercoagulability? Okay, all right. So, yes? Right, right. I was not the treating physician. That all happened in Colorado. But what I'm saying is, like I told you in the beginning, this scenario is not the true scenario. I added a few things. I took things away just to make it more fun, okay? Like the pulmonary functions, it was never done, but I put it there, just in case you asked. I wanted to be ready for every question, okay? So let's see what is happening here. Oh, well, you didn't think I came from San Diego to give you a case of acute pulmonary embolism with TPA, right? That's not it. So we're not done yet. 1 month later, Jose shows up in the office, August 20th, and says, "Doctor, I feel terrible. I can't breathe. His dyspneic, his orthopneic, his chest pains, palpitations on exertion, lower extremity edema, his pro-BNP is rising." And I say, "Jose, you have to go to the hospital." He tries to reject, but I insist, and Jose is being admitted again to the hospital, all right? Now, at the hospital, we want to think what's happening. We thought we had the right diagnosis. He had a PE. We treated with thrombolytics. He's been compliant with his anticoagulation therapy. So what is happening? Why is he now getting worse? So I say, let's do the following. Which test? Echo again showed the same things. The RV is only bigger. Okay, you want to see if he's hypercoagulable. Okay, what else? Okay, CT pulmonary angio, see if we still have blockages. Okay, what else? Cardiac cath. Right heart cath. Okay, what else? Okay, so coagulation workup. What else? Okay, very good. Okay, these are all good suggestions. Let's see what the hospital did. They put him in the scanner for a VQ scan. You guys agree? Okay, good. And this is what we found on the VQ scan. I'm going to enlarge it so you can see it better. We have multiple unmatched perfusion defects in both lungs. So we still have areas that are not perfused. So the pathology in the pulmonary circulation remains. Okay, and next we take him to the cath lab. We do the right heart cath. What do we find? And what we found was a surprise, big surprise. Look at that. Look at those numbers. Look at how high the pressures are in the right ventricle, in the pulmonary artery. I'm going to try to point. I hope it works. Is it working? Can you see? Okay. So look at the pressures in the right ventricle and in the pulmonary artery, up to 98 systolic. The cardiac index is very poor, 1.3. Look at the pulmonary vascular resistance, 1600, very, very high. It's about to kill the guy. and his mixed saturation is 50%, indicating that his cardiac output is lousy. So this guy is going to die unless we do something. The next slide is going to be pulmonary angio, invasive pulmonary angiography, and it is showing certain defects that need to be dealt with. At that point, the patient is transferred to UCSD for a diagnosis of CTEPH, which is usually the case. When you treat pulmonary emboli, they don't go away. Then you start thinking about something that does not dissolve with TPA and anticoagulation, something that is so resistant to thrombolytics. And that is what? An organized clot that is called CTEPH, or chronic thromboembolic pulmonary hypertension. Okay? So, at UCSD, these are his numbers. As you saw, his right atrium pressure is high. His pulmonary vascular resistance is so high. His cardiac index is so poor. Something needs to be done. So, is this patient a candidate for pulmonary thromboendarterectomy? That's opening the pulmonary artery and taking all the junk out. Is he a candidate or not? Show me hands. Yes or not? Are you in favor of surgery? Of course, it is the only curative intervention for this disease. You can do drugs and medications, everything, but they don't work as well. So here is the UCSD team working on the patient, PTE surgery. Of course, you know this guy, Michael Madani. He's one of the most renowned surgeons. This is how they do the surgery. Hypothermic technique, complete arrest of circulation, open up the pulmonary artery, and take out this. See what it looks like? That's like rubber. I don't even call it a clot anymore. It's an organized clot, but it looks like rubber, right? This is not going to go away with TPA, apixaban, or all the anticoagulation in the world. You really have to get in and take it out. And that's what the team did. Under the microscope, this is what it looks like. You're going to see red cells, white cells, but in the middle you see all the organization, all the collagen and the fiber. Now, as a good center would do, we have pre and post-op right heart cath to compare the numbers. And look at what happened. Look at the pulmonary vascular resistance dropping from 1,400, almost 1,500 there, to only 134. That's more than 10-fold drop in pulmonary vascular resistance. Look at the improvement in cardiac output and cardiac index. From 2 liters jumping to 5.3 liters, completely normal. And the patient is a completely normal and a new person. And they do another VQ to make sure all the unmatched defects are gone. And it confirms. One thing I wanted to mention to you, when I'm treating a patient with acute pulmonary embolism or acute pulmonary pathology, because that filling defect doesn't tell me. It could be pulmonary sarcoma, for all I know, right? So how would I know? There's one feature on this CAT scan that is very nice, and I like very much. Look at those arrows, and I'm going to try to get them here. Those arrows here, you know what they're pointing at? You know what that structure is? One here, one there. Those are the bronchial arteries, and they tend to enlarge when you have chronic pulmonary hypertension. As the pressure builds up in the pulmonary circulation, the bronchial arteries become engorged. And that is a sign to tell you this is not an acute problem. This has been building up over time. And that would have been a clue that you're dealing with a case of CTEPH, not simple acute pulmonary embolism. I like that clue. And obviously, you see the big ventricle and everything, and the shift of the septum. And it's worthy to mention that with the enlargement of the bronchial arteries, they can actually compress the left main coronary. And patients may present with like angina and acute MI when actually the problem is in the bronchial circulation. One word, and you know I'm biased. Is that for me? Okay. This is my last slide, and obviously I am biased, so UCSD remains #1 in the world, worldwide, dealing with pulmonary CTEPH because they have done more than 4,000 cases, and they have more success than any other center in the world, and they have the lowest post-operative mortality worldwide. I had prepared something about CTEPH, but I know the next speaker will tell you all about it, And I'm going to stop here, and thank you for helping me with the diagnosis.
Thank you very much, Dr. Islam. As usual, yani, you are